Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Organon.
Hello, I'm Lawrence Eichenfield. I'm a professor of dermatology and pediatrics at the University of California, San Diego, and Rady Children's Hospital, where I also direct the pediatric dermatology unit. And welcome to this program titled Framing the Future of Topical Therapies in Atopic Dermatitis. Joining me today are Nanette Silverberg. Nanette?
Hi, thank you. I am a clinical professor of dermatology and pediatrics at Mount Sinai in New York City and chief of pediatric dermatology for the Mount Sinai Health Systems.
And Shauna Moranti.
How are you? I'm Shannon Moranti. I'm a dermatology PA from Naples, Florida, and I practice both adult and pediatric dermatology.
Well, welcome to both of you. We have, I think, a great session today. We're coming at a time point where our management of atopic dermatitis is really evolving. And that's happened both with systemic agents, but also with topical agents. There's a set of newly approved topical nonsteroidal medications that we're really happy to have in our armamentarium to help us take care of atopic dermatitis. So today we'll have a discussion that's focused on how to use these medications in atopic dermatitis care. We decided to set this up really through a case-based discussion, but going down to get a little drill down on some of the data behind our newer medicines. So we'll talk through a couple of cases and go through our sort of newer agents, newer non-steroidal topical agents that can help you and us to take care of our patients with atopic dermatitis. So the first case is Reggie. He's a 4-year-old preschooler with a history of atopic dermatitis that was diagnosed at about 1.5 years of age, not an uncommon time frame. He has about 9 to 10% of his body involved with eczema on his arms and legs, a little bit also on the neck, and a little bit on the eyelids as well. So, we remember that about a hand is about 1% of the body of an individual. So if he's got 9 to 10 hands worth of eczema. He's currently being treated with topical corticosteroids, low potency for the face and a little stronger one for the body. Family reports that Reggie's quite comfortable. The mom says he's doing better, but he can get worse intermittently. So I guess, one of the questions that I'll raise is, in this case, in this 4-year-old, what are the nonsteroidal options for this patient? And then, we'll go through some of the information about how do we figure out when to use what, when.
Certainly, we have to consider for Reggie his age in this case, because we have a lot of fantastic options now for atopic dermatitis patients. But for his body surface area, which is less than 10%, and for his age, which is under 5 years old, we just have a few of these non-steroidal options. And we are so lucky to practice medicine at a time that we have options beyond topical steroids. There's a lot of patients, that of course are a little bit timid to use topical steroids or worried about using topical steroids for a long term for a chronic disease. So our non-steroidal options that are FDA indicated for a child of this age of 4 years old would be our topical calcineurin inhibitors, which of course have a 2-year-old and up age indication. And that would be our pimecrolimus, which is FDA approved for mild to moderate atopic dermatitis for 2 and up. And then the tacrolimus, which at the 0.03% is indicated for the 2 to 15 age range. The 0.1% is only indicated for 16 and up. So it would be that lower strength tacrolimus that's also indicated for Reggie. Crisaborole is a topical PDE4 inhibitor, and that was FDA approved for 3 months of age and older. But for any of you that have prescribed this in the past, you may know that it comes with some adverse events that are sometimes unfavorable, including burning and stinging. Tapinarof is the newest on the market for this age indication. It does have an age indication of 2 years of age and older. It is a topical aryl hydrocarbon receptor agonist and can be used from head to toe, from eyelids to body folds to the backs of the knees to the antecubital fossas. So we can kind of simplify patients' regimens and simplify the regimen for the parents that are struggling to chase these kiddos down at the end of a busy day. So it's nice to have options. Dr. Silverberg, I'd love to hear your take on some of the data behind some of these options and maybe some of those adverse events that I was alluding to.
So I think that we have the good fortune to live in times when we have so many options, and it's not always clear what the best option is. And part of choosing options, of course, is shared decision making. And I like to use data in my practice. I think that parents respond to data. So let's start with crisaborole. Again, a PDE4 inhibitor, an extremely safe class of drugs, even in the systemic versions, no, concerning adverse events. However, we do see this stinging and burning, which can be a little more common even in our younger patients in real world practice. But definitely producing excellent results and sometimes excellent results in surprising areas like hands and feet, where we often want to use stronger products. And yeah, nice outcomes. And also now FDA approved for twice daily for active disease and once daily for prevention. And I think that's been something, I like in my practice. So, 4-year-old obviously doesn't have those two red cheeks that I see in infants, but certainly a very versatile product as long as you tolerate it. If you don't tolerate it, that's an issue. And I encourage people to do it in a cool room, not necessarily to do it right after bathing. Let them cool down, moisturize. Put it on the affected areas. But definitely superior to placebo, great safety, can go any place, and really a favorite of moms from a perspective that it's not a steroid. And I think that's something that we have to account for. That many of our patients don't get any treatment at all if we hand the parent a topical steroid and the parent is steroid phobic. So to pin her off, I have a little trouble remembering the age cutoffs on these products, so I refer to it as to pin her off, so I can remember that it's 2 years of age and older. So it's to pin her off in my real world practice, and so 2 and over. And again, in these clinical trials, showing significant benefit in reducing the overall surface area, in reducing the overall severity. And we're seeing excellent results with a once daily product, safe for all surfaces. Newer agents, so it's a little bit harder to incorporate into your practice and to understand the efficacy. But of course, we have so many patients in our practices that have already failed the standard treatments that were available until about a year or two ago. So we certainly have individuals who have had multiple topical agent failures, and it's really nice to have the ability to treat through an alternative modality. Again, a rather safe modality as well, and very minimal adverse events. So similar to all the nonsteroidals, safe enough to keep going until you get to fully clear.
So Shanna mentioned it's an aryl hydrocarbon receptor agonist. And, for most of us still, it's like, okay, what does that mean? It's a very interesting, it's a different pathway. It's an anti-inflammatory pathway that also has an antioxidant aspects to it. It's sort of a, balances the yin to the yang. It has these environmental corrective uh, uh, mechanisms that play out, but it works as an anti-inflammatory. The other thing is in their long-term trial, um, they did very well when areas clear. Areas can stay clear for 75 days without ongoing medication. So they sort of did rather than go to a prophylactic model. They were went to a sort of, does it come under control? Do you have a localized remission with that? And that was something they had seen in some of the psoriasis trials. So it's pretty intriguing in clinical practice.
So do you guarantee that to your patients? It's something that's seen in practice, in the trials, but I'm always a little careful with how I word that with parents because, you know, it's not something you can guarantee with any product. If you do achieve clearance, you'll stay clear. Um, but how do you word that with your parents?
Well, I like to bring the suggestion in that there can be long-term disease control that doesn't require medicine all the time. Because don't forget, most of them are coming in with this fear of topical steroids. Sometimes the steroids have worked, but then they underutilize them because they're afraid about ongoing use of it. And I'm trying to establish a set of nonsteroidal medicines that can be used without those concerns. They can be used continuously if needed, but in most of our clinical trials, many of them can be used intermittently or on an as needed basis. So particularly with the Tapinarof, I can say, in the clinical studies, they used it once a day for 8 weeks and then as needed over a year. And they found that a lot of patients would come under control and then wouldn't need any medicine for an extended period of time. And if it works that way for you, that'll be great.
I think it also alludes to the ease of use, but also, parents understand that this is a disease that waxes and wanes, and they like the simplification of being able to use one product that they can go to daily, once a day instead of BID, and daily until clear. And then when you're clear, you can actually stop and potentially maintain clearance, as was seen in the clinical trials. And then when flared, go back to the same product. They don't have to go back and bring out their instruction sheet and figure out, okay, which tube was I supposed to use on the elbows and the knees, and which tube was I supposed to use in the face? And I haven't brought these tubes out in a while, and I forget which one goes where. So, as a mom of 4 kids, I know that simplifying the regimen for the patient is often, heard with a lot of gratitude on the parent's end.
My issue in my practice is that parents actually send me messages through our system requesting permission to put products in different locations for assorted flares. And I can just say to them up front with an agent like Tapinarof that you don't have to ask me. You can use it any place except, don't put it inside the mouth. You don't have to eat it. But, you can use it any place, and you don't need my permission. You can just go for it. I give you blanket permission, and it is very helpful.
Now, I do tell, in my more sophisticated parents, I'm really letting them know about the relative safety of the products and where they come from by history, right? So we have calcineurin inhibitors. Those are drugs. One of them was an immunosuppressant, right, systemically, that was then sort of transported into topical use with topical formulations and generally shown safe despite the safety warnings that they got, when they were rolled out back at the turn of the century, so to speak, around 2000 and 2001. The aryl hydrocarbon receptor agonist, tapinarof, you can't find it in the bloodstream. It's fascinating that it's sort of, so that brings a lot of safety to it. In this age group, we don't have alternatives of topical ruxolitinib. That's a very strong medicine that has topical formulations, but with limitations of body surface area. That's one thing that we don't have limits in the drugs that we discuss. So there's a ease of discussion with the family about how they may use it, but also with safety. Now, a consideration in this case also was age. So, any particular recommendations for Reggie, the 4-year-old with facial and extremity um, eczema?
we always do a lot of shared decision making. And no matter what, we always start with the basics, the home, the skincare, and what are you doing? Um, but I think that, all of these agents are potentially efficacious, but, you have an agent like tapinarof is a slam dunk as a once daily agent, can go every place. We can bring patients back in a few weeks, and if there's some areas that aren't perfect, you can always add something else in. But I rarely have that issue. I'm finding very parents are able to stay on the regimen longer, with less need for alteration. And we used to tweak our products a lot when we were having, like, our paint by number, topical steroids low here and high there, and medium there, and this is just something that totally has changed the way that we can approach atopic dermatitis with a simplicity and um, a single line for our eczema care guide, which has never really been heard of.
No, I think that's great because I think really we're trying to get long-term disease control. We're trying to figure out what we need to get long-term disease control, and you have this option of using a single agent as needed. So I do think that's part of the excitement of
Keep it simple.
newer non-steroids in care. Yeah. So we move over to the second case. We're going up in age here. We'll have Samantha is a 15-year-old teenager with atopic dermatitis. It was moderate for most of her childhood. She seems a little annoyed with her eczema. She's inadequately controlled, complains of a lot of itch. She's got eczema on her face. She's got eczema on the dorsal surface of the hands. She's got thigh eczema as well. She's relating that, she's 15. She's worried about how she appears to her her classmates and friends. She's been managing with a combination of topical corticosteroids and calcineurin inhibitors, and she's both asking for a better fix. She wants efficacy. She'd like an uncomplicated regimen, and she comes in super concerned about topical steroid because she heard about topical steroid addiction in her social media feeds. And this is like a real life issue we face in clinical practice all the time. So why don't we start off with itch? Anyone want to weigh in about how itch influences our patients when they are really itchy?
So, of course, itch is such a difficult symptom for these patients. They come in complaining of itch and moderate disease for most of her pediatric life and into her young adult life is very difficult. So they want something that will give them that itch relief and give them itch relief quickly.
I think that the issue always with itch is not is that we our patients experience it most intensely in the evening, particularly shortly after they go to sleep. There seems to be a peak of itching when there are less distractions, when your temperature rises a touch. All kinds of components of itch. Some of it is experienced as pain, some of it is just experienced as itch. Um, but it basically is torture for the household because the child is up, the parents are up, and then when it comes to the teenager, they get into long-term poor sleep habits that really prevent them from functioning the next day in school, and they miss school, or they're too sleepy to really make a go of it. And 9 missed days of school means failing math is higher risk. So we really need to be mindful that our patients who are thinking about college, they can't be up all night with itch.
Yeah, I agree. I really try to preach this minimal rash, minimal itch, and minimal sleep disturbance is what I'm going for, and get that out there as something to work with. So options for a 15-year-old. So we have our traditional topical corticosteroids, but she's like freaked out about it. She used some TCIs, not feeling it's bringing enough efficacy. At 15, we have an we have, a broader set of options of a non-steroids, right?
We sure do. So roflumilast, of course, tapinarof is FDA approved for 2 and up. We also have roflumilast, which is a topical PDE4 inhibitor that has FDA approval currently at the 0.15% cream for ages 6 years of age and older. And we have ruxolitinib, currently FDA approved for 12 years of age and older. Again, coming down the pipeline, we may see some younger age indications. But as we record today, that is our current age indication. All three of these are possibilities for our patient here because she is the proper age indication. She's frustrated. She's tried and failed topical corticosteroids and TCIs. So we have some options here. And it's nice to be able to kind of look through the data and decide what might be best for her.
Yeah, and what's interesting is that these options are all three different classes of drugs, right? Tapinarof, this unusual aryl hydrocarbon receptor agonist, this novel pathway. Roflumilast is a PDE4 phosphodiesterase inhibitor, but different than traditional crisaborals, a different agent. It's been approved at higher concentration for psoriasis and seborrheic dermatitis, and then in this concentration is discussed six and up for atopic dermatitis. And then ruxolitinib is a topical JAK inhibitor, actually the first JAK inhibitor we had in the United States that was approved as a topical. It does have a limitation of body surface area of 20%, so it wouldn't be something you'd use in higher percent body surface area than that because of concerns about absorption, but a really nice, interesting set of different products that you can use.
I think one of the advantages of tapinarof and roflumilast is the creams are, I think, and the foam aspects of different agents offer some options regarding tolerability, particularly for facial disease in teens, where you have some concern about acne. But the itch reduction is stellar. You see rapid reduction in itch, 1 week, 2 weeks, and just ever expanding improvement over vehicle over time. With tapinarof and then roflumilast, able to use this product just on large surface area. I like it for teens for head and neck because they often have this overlap with a little seborrheic dermatitis at 15. So, you get that dual control, although, conceptually they may be different concentrations, we see benefit. And you see that over the course of a few weeks, you're not just seeing reduction in IgA, but you're seeing like a clear increase in itch-free time and itch improvement that steadily increases over vehicle. And I think this is something new for us in atopic dermatitis data. Many of our older agents really were fairly close to vehicle. Some of the original crisaborole studies were, it took a little while for that to appear. And here you're seeing a clear break very quickly.
I love that you brought up the Sebderm AD crossover because we see that so often in our teenage patients, and that's I think where roflumilast really shines. It is a once a day. Currently only the cream at the 0.15% is FDA approved for atopic dermatitis, but we also have a foam version of roflumilast FDA approved for seborrheic dermatitis. So it's nice to know that for those kiddos with AD and sebderm, we may have some efficacy there if they have facial seborrheic dermatitis in addition to their eczema. But I do love to see that nice improvement in IgA with just a once a day product. Their studies were done in just 4 weeks, which was great.
And then we have ruxolitinib as well, which we already pointed out has been approved ages 12 years of age and older. There's some younger data sets that are being processed right now. That drug is also, as it was the first drug we had approved for vitiligo, very consistent clinical response as a JAK inhibitor, rapid response on itch as well, and very good efficacy. Again, it's restricted in terms of the body surface area, but brings lots of efficacy and another incredibly nice non-steroidal option for the 15-year-old who we're discussing with it. Itch improvement is very rapid. That's a hallmark of JAK inhibitors orally or topically in terms of a rapid clinical response and very good clinical data set to support its use. So I guess I'm going to lead in and I think what's so important about this case is that as a dermatologist, and a pediatric dermatologist in particular, I spend a lot of my life sort of defending topical corticosteroids and their appropriate place in therapy. But at the same time, I do wonder if we're over defending it to a degree because we have very good nonsteroidal options that may be taken up by patients.
It's so important to acknowledge that our patients have access to data online, and there have been flags raised about corticosteroids, and some of it is phobia, but there are individuals who just are getting adverse events, and particularly this young lady is at risk, right? Because she has inner thighs. And putting a topical steroid on the inner thighs in a teenage girl who's 15, who has a 70% chance of developing stria in that region on a good day without any treatment, if you put anything of a weighty class 2, class 3, you really run a high risk. So here in this particular location, all of these topicals would be very reasonable therapeutically. Thinking about, perhaps some of them being a little more rapid onset of itch reduction, some of them being different. But you might want to also think about the issue of putting topical ruxolitinib on the face, and some of the teenagers do get a bit of localized acne. So we do have to think about locations, but that particular inner thigh location, all of these agents are so superior to the topical steroids in that respect. But we also have to think about how nice it is to have creams. Here are agents we can give, rub in nicely. Can put some of them we can just do once a day at night. And so we have so much an improvement in terms of quality of life and satisfaction regarding the agent and the usage for a teenager, and that just makes their lives so much more enriched, and so much improvement in quality of life.
I agree with you on the creams too. I practice in Southwest Florida in a warm, very humid climate, and patients are not always fans of ointments, although we know sometimes they have a little bit better efficacy. But topical corticosteroids are never going away, and we truly will always need them, I do believe. But having these new agents available allows us to practice topical corticosteroid stewardship and truly save those topical steroids for the cases that we need them, and potentially be able to use these nonsteroidal agents on cases that we might have chosen topical steroids in the past.
And I think it's hard to say which drug would I use on the patient, because to be truthful, that what we do is we discuss the options with the patient. We try to figure out which ones are going to be covered or have reasonable access, which varies from insurer to insurer and patient to patient. We want to be very positive about the utility and how they can be used shorter term and longer term. I think we all have our methods of sort of feeling out and mixing and matching, which we think of the agents will be the one we go with. But I want the people watching this to know how excited we are with this newer set of nonsteroidal topicals and how they really bring a ton with them. We're at the point where we should be finishing up. Any key points that you'd like people to take away from today's session? Shauna, you want to start what you think?
So wonderful that we have options for our atopic dermatitis patients down to very young age indications. So I love having the potential to prescribe a lot of these newest, latest, greatest beyond steroidals or non-steroidal options.
I think that my takeaway is that having these options requires some discussion, and a lot of planning with families and with patients, especially our older patients. And I think that at this point, everybody can find an agent that works for them that they're going to feel comfortable using. And I think that that has is something so exciting, that we can offer people these new agents that are appealing in so many ways and efficacious.
And I'll end up just saying that I think I see a lot of patients every day in practice who just have historically been insufficiently managed, and they just haven't had, they're not where they could be. And a lot of it's because of concerns of, their traditional topical steroids, and that we're in a new age. And that's really what we wanted to represent in our discussion today. So thank you. I thank my colleagues for a great discussion, and thank the audience for participating. Please continue on to answer the questions that follow and to complete the evaluation. Thank you.